And I came from a health plan administration and human resources background. I operationalize things. That's what I do. And I wanted to use my skills for the community to stop somebody else's sister from dying unnecessarily, to make sure the next person got to what they needed at the right time. I can't say we get there all the time in time, but we work with a lot of families and a lot of healthcare providers around the world to make sure that patients with HCM and big heart muscle disorders get the care that they need, deserve, and should get. So that's why I did it.
Which
That
is
makes sense?
absolutely, and it's incredible to, yeah, like I said, to take that grief and turn it into something so positive. So it sounds like the website, has it always been 4hcm.org, the number
Yep.
4
No, actually,
hcm.org?
it wasn't.
Okay.
It started out, and I got to give some props back to my old bosses. It was originally part of Cantor Auto Products, Kanter, cantorautoproducts.com/HCMA-heart. That was the first URL because I didn't know how to build a website, and my boss let me anchor it onto the business at that time. So that was Dan Cantor, who passed away just a couple of weeks ago. So
Oh,
props to Dan,
thank you, Dan.
who was amazing, and his brother Fred, who's still with us. So thanks to Fred and Dan Cantor for that launching opportunity. But within about a year, I turned it on. I got another provider who helped us figure out how to get a website up before, all the widget tools were available. I had to learn HTML programming. So that was fun. And our first website under 4hcm.org probably went out in 97. The original one went out in 95, 96. And then 4hcm.org has been around since 97. I wanted 4hcma, but the Hispanic Health Ministries organization took it first.
Ah, you were too late.
I was too late. Missed it. So
So you've got the website and you're starting to compile these resources. I heard you reference on the Tales from the Heart episode recently with Marty Marin that one of the first calls that you made was to his father, Dr. Barry Marin, HCM guru that he is, and you asked him some questions. You said, "How can I get this guy to help me and help this organization?" What was that conversation like, and what were the first sort of actionable steps that you guys took after you had that conversation?
oh boy, that's a complicated one. So in the other room, I still have this pink 3-ring binder that has some of my original notes in it. And I had called Barry Marin's office, talked to his secretary, who at that point was a woman named Terry. And I said, I'm a patient with HCM. I think I want to build a support organization. I'd like to talk to Dr. Marin and see what he has to say about it. And he called me back. He's like, who are you? What do you want? It was kind of funny. And I'm like, I don't know what I want to do yet, but there's nothing out here for us. I had called some very large organizations in the heart space and said, here's my diagnosis. My sister just died. What do I do? And they said, talk to your doctor.
Mm.
But the doctor that was caring for me and my sister, I wasn't feeling actually had my best interest at heart at that point, pun intended. But I wanted to make sure that I was asking the right questions. So Barry was kind and generous with his time. I like to refer to it as my medical education through thermal paper fax machine. Barry would send me articles and I would read them, and I would call him once or twice a week. We'd have lunch together over the phone and I'd ask him questions. What about this and what about that? And he'd give me another article to read, and we would have another conversation. And I would then I was collecting questions from the community. Here's my situation. What do I do? I'm like, I never heard of that one before. I didn't know that was possible. So I would document it. I would write it up. It would become content for the web page. I would get an answer from, it started with Dr. Marin, but I will give props to the other docs who were the early innovators here. And that's Dr. Harry Lever, Dr. Mark Sherritt, Dr. Christine Seidman, Dr. Bill McKenna from UK. So these were some of my early mentors and helper bees to learn the clinical part of HCM while I was actually helping them see the problems through the lens of the patient and showing them that there were these larger pots of people who were experiencing similar types of problems related to their HCM. And God bless them, they would show up at our annual meetings. They would be there with the patients to hear the questions, and it would spark more articles to be produced. So Barry would listen to the patient questions, it would spark something, and 16, 18 months later, you got a full research paper on it. So if you look at the publication numbers in HCM, they're kind of in the 70s and 80s. There's a couple papers a year. 80s, 90s, 2000s, it starts to explode. And you're just seeing lots of new data. And a lot of that was facilitated by conversations in a really complex ecosystem that we made very small. We'd have our patient meeting, and the patients and the clinicians and industry folks would all sit and meet together and hear the lived experience of patients and then try to find mechanisms to make their lives better.
So you started the patient meetings fairly early on.
In the 90s. I think the first one was 90. Not sure if it was 96 or 97, but I can tell you it was at the Parsippany Hill Inn in New Jersey, and it was a small room, and there was about 50 of us that showed up, and I thought that was amazing.
It is.
Amazing. 50 people in a room talking about HCM. And we said, that was fun. Let's do it again. The first social event after an HCMA meeting was on my back deck at my house. We just had everybody come back to my house.
Perfect.
So it had to be 97 because I moved in there in 97.
Okay.
So that would be the first year.
Did you base any of this on observing other patient advocates or other patient advocacy organizations? Or we all know you're a go-getter, and like you referenced, you worked in HR, you are a person who likes to systematize things. I deeply relate to that. But did you study other people's work, or did you really just dive into this on your own and see what worked for the HCMA?
The model that I started with, I didn't mirror anybody because, frankly, it was a little early to be able to mirror another organization in terms of services and structures because there wasn't a lot on the internet. We were one of the first patient advocacy groups on the internet. So there wasn't a lot out there. Now you can look to the large organizations to see what they do. American Diabetes, American Cancer, American Heart, but we're not them. We're dealing directly with individual patients and clinicians and making a care model. So what I did do was I opened the phone lines and I talked to a lot of people early on. What do you need? Where isn't it working? What is working? What would make you feel better? What do you feel about implantable devices? What do you feel about medications? Can you travel to a doctor? There was a lot of base work that I was doing in understanding the journey from beyond my own lens. So I looked at the journey of the patient, and then I looked at modeling of programs. So I was referring a lot of people to Dr. Marin in Minnesota, but you've got to get on an airplane and you got to fly to Minnesota and your insurance has got to cover it. So there was a lot of hurdles that the average person might not be able to get on an airplane and go someplace. So as I was looking at how Dr. Marin managed his patients and what I had experienced at NIH before it broke in the HCM program, because there was some really good structure there. Then I looked at what they were doing at the Cleveland Clinic and at the Mayo Clinic and how the model of care was working there. And then we sat down pen to paper as a board and we said, what's missing? Is there more that we should be doing in the care model for those with HCM? And I was going out to AHA and ACC and I was meeting cardiologists and I was talking about care models. And I was encouraging these young doctors to take HCM as a career path, not a part of cardiology, but making it a career path, that this would be their focus. And they took me up on it, a lot of them. And we started to develop the modern HCM program, which actually came from, it has its roots with Barry Marin. One of the physicians that he worked with back at the NIH in the early 80s was a guy named Jim Udelson, who became the chief of cardiology up at Tufts. And he said, I want to build a modern HCM program, and I think I want Marty Marin to come help run it. And that's when Marty was just coming out of his fellowship. And Marty started the program at Tufts, and Jim said, "What's the model?" And I said, "This is what I'd like the model to be." And he was the first modern HCM program. And then I got a call from a guy out at Stanford named Ewan Ashley, who said, "Bill McKenna said to call you about what we should do about HCM programming in the United States." And I'm like, "And here's a model." And then Charlene Day called at University of Michigan, and I'm like, "And here's a model." And then it just started to go. So we have our base legacy programs, I call them. And then you have the ones that grew post 2004-5 and onward, which coincides with the time that I gave up my day job in HR. And in 2005, I came to HCMA full time. And it took me until 2 years ago to get my salary back that I was making back then. So there's, I don't talk about that kind of stuff a lot, but the early days, my husband and I funded the work of the HCMA. We didn't have any funding. We built it because we wanted to. And we may not have had vacations, but we built a nonprofit organization. That's where we decided to put our resources. So it took a long time. It took a lot of sacrifice. It took a lot of hours, and a lot of really challenging conversations. Patients don't always do well with HCM. So we learn as much from those living with HCM as those passed from complications of HCM. So taking each one of those stories and turning them into a learning and turning them into something that we can take to clinicians and say, "Hey, watch out for this. We're seeing this. This got missed." And having those conversations and bringing those patient stories to light has really made all the difference in what patients can expect today when they get diagnosed with HCM.
And it sounds like it really snowballed from that, the inception of the idea of a center of excellence, of a model of care, and then having those doctors start to reach out to you. I think that probably reflects the fact that there was already a need for this, and somebody just needed to put the structure in place to make it happen. And now there are 60, how many centers of excellence?
60 programs at this time. And there are a handful under evaluation right now. So you might be hearing some new centers being announced over the next couple of weeks. It's an ever-growing process. I don't believe that there will ever be thousands of these programs, but I do believe we'll add in another 20 or 30 over the next few years in the United States. Not every center is an exact replica of the others. Each institution has its own uniqueness, and we try to work with that institution and that catchment area to build a program that works for the community there. My original goal, my original office, I had a laminated map, and I had little arrows and stickies all over it. But across the top, I said 5 hours. And my goal was a 5-hour drive for most Americans, because at that point, I was driving 5 hours from New Jersey to Boston. And if I can drive 5 hours, you can drive 5 hours. That was kind of my original line in the sand. Not that there's any like real deep science there. It was just a number, right? You got to start somewhere. And then it turns out that today, most Americans by population are within an hour and a half of an HCMA recognized center of excellence, if you go by population density. There are places where we still have, deserts and gaps in the map that we look to maybe in the future bring in more virtual medicine options so that patients can get virtual medicine delivered with coordination with their local doctors. So who knows what the future of centers will be.
Incredible. Was there, maybe it's the inception of the centers of excellence, or you being able to focus fully on the HCMA starting in 2005, maybe it's something else, but was there a moment when you said to yourself, this is working, this HCMA thing is going to be a success? Was there a specific accomplishment or moment that you had that feeling?
I am probably my own hardest critic, because I'm always excited when we have a new partner who wants to care for patients and they've got a great model and their institution supports them. and you go, yes, it's working here, and you go, yay. And then you turn around and you see prior authorizations put in the way of everybody getting access to care, and that the health systems are now having to spend all this time and money on administrative things that are blocking actual patient care that frustrate the hell out of me. So it's always seems like a constant journey of 2 steps forward, 1 step back, 2 steps forward, half step back. So we're making progress, but it's never linear forward. It's always kind of, here's the plus, here's the minus, how do we navigate? I would say to anybody who sees, patient advocacy as something that they want to get involved with, you need to be able to really focus on the future, because you're going to get stopped in a lot of ways, but you're going to move in a lot of ways. You're going to look for your pathways through change, and they're not always as obvious as you think. But sometimes if you get a little creative, you might get people's attention in a completely different way. I have another edition of the podcast that's going out this year that's very different than what I've done in the past, and it's called Deconstructing Healthcare. We want everybody to have an understanding of what our healthcare system is actually based upon, not the political rhetoric, because that's distracting. Like, how did we as a country, and I'm talking US based here, how did we as a country determine what our healthcare structure was going to be? And on what rule of law is that based? And what changes could happen to that law that might change our individual access to care as patients? I think it's really important that we talk about. I think it's really important that no matter the disease state, that we actually start having that conversation as to who are we as a people and what do we believe people should have access to in terms of healthcare. So in deconstructing healthcare, today we're recording this on January 16th. So we talked about the basics of what happened in the 40s with healthcare. What is so important about 1965 and 1974 and 1984 and 1985? What laws came in that changed our access? So understanding the laws, which are built based on public policy, and where are we going forward with healthcare, because we're not going backwards. We're not going back to pre-World War II, where we didn't have private health insurance. We didn't have half of the meds that we have today, or 90% of the meds we have today. We're going forward. How do we deliver the promise of precision medicine in the future? We now know the genes that cause HCM. We now have clinical trials that are looking at gene therapy to stop the disease. If that's the path we want to go to stop disease potentially, how do we get there? How do we fund it? How do we structure it? We got to have hard conversations, and we need to lean in, not lean back. I built an organization from anger and grief, and they're powerful, and they've carried me for 30 years. Anger and grief. Anger doesn't have to be a bad thing. I'm angry at the system that existed that allowed my sister to die at the age of 36. So let's focus on what we can do to change it. Now that gets us into a little kind of a dicey situation in the current day. As soon as I said policy, there's a bunch of you who are listening who went, ugh, I don't want to deal with it. It's politics. It's not politics, it's policy. There's a difference.
Yeah.
Policies are made through the regulatory process, which politicians run. But it's not political. It's policy. It's governance. So let's think about it that way, because we all need it. We
do. And from the perspective of the HCM individual patient, I had one of my online discussion groups last night, and almost every month, some of these logistical questions come up. People want to know, what is the real life impact of that those policies will have on them, on their ability to access care through their local cardiologist, through their center of excellence, through access to the medications that they've been prescribed by those doctors. So people want to know how it will impact their day-to-day life. And I think it's great that you're doing a series that will address those topics in an apolitical fashion. So
Apolitical is the key word that we have to talk about here,
yeah.
because I don't want to, you start talking my policy versus your policy in a political realm, we stop seeing each other as living, breathing humans,
Mm-hmm.
right? We all have our own health issues that we're trying to contend with, whether it be a minor issue or a complex chronic disease that needs management. At the end of the day, we all want the same thing. We want to live our one wild and precious life the way we choose.
Mm.
And I want everybody to be able to access healthcare at the level that they want and need. You're all going to make individual decisions. Probably one of the most complicated questions somebody could pose me with was, what would you do if you were me? I won't answer it because I'm not you.
Yeah.
But I can tell you, you have some options. And here are your individual options. Here's who you can work with to make the right choice for you and your family. And we're here to help you through that process of figuring out what is right for you. And in HCM, the model is very, very, very personal. So our intake and our navigation process is an individual process that I can't figure out another way to do this. And I've thought of it, but it's one-on-one. It's, what is your family history? What are your issues? What do you need to get access to? I'll use an example, and we'll just use this as client A. So let's say client A has a pacemaker or defibrillator, and that device needs to be replaced, but they're pacemaker dependent, and that's a rare bird, and this is a tricky procedure. We know who the handful of people are that can handle those really complicated lead extraction cases, and we make sure that those people are connected, because I've built a resource of 30 years of expertise and friendships and relationships, where when we need to call on somebody, we know where to go. So rather than you hunting through the internet trying to find the right person, we have somebody we've met, we know, they're vetted, they're published, we know their history. Go talk to them. And aligning the right people at the right time makes all the difference in healthcare delivery.
Absolutely. And I'm happy to self-identify as patient A, because Lisa and I did have that exact conversation, and she directed me to find the surgeon that did my lead extraction and ICD replacement, because I am a super complicated case, and she put me in excellent